Good evening, fellow physicians from around the world. Welcome to Cases and Updates 2024 by Pain Management Network. I am Dr. Jessica, and I am the moderator for today's event from Pain Management Network. I would like to introduce Pain Management Network as a network of pain-focused physicians, which was established in 2019. We have various programs, particularly learning programs of pain management and interventional pain management. And we already have hundreds of alumni of our programs who have practiced pain management in their clinical practices, and also they have helped a lot of patients in which they have benefited from our program. So for today's event, we have several agendas. The first is case presentations by the alumni of our previous program, 3MLP Basic Course, USG Guided IPM on Musculoskeletal System. And then we have case presentations about spinal intervention for low back pain, which is our main topic for today. And don't forget to stay tuned until the end of the webinar because we have gift vouchers for our upcoming programs for best participants with the best questions. Okay, so before we get to the presentations, I would like to proudly introduce our faculty of Pain Management Network. I would like to read the CV of Dr. Novi. Okay, so to me and to many people, Dr. Novi is a Wonder Woman because she plays many roles so excellently as a pain physician, as a lecturer. She also has her academics and organization so well, and she is also a mom and a woman with her own hobbies. Next. For her education, Dr. Novi obtained her GP, Master of Science in Sports Medicine and Physiology, Master of Science in Medical Nutrition, and also Physiatrist from Universitas Pajajaran. And she also obtained Fellow of Interventional Pain Management and FIPP, Fellow of Interventional Pain Practice, and also CIPS, Certified Interventional Pain Sonologist from the World Institute of Pain in 2017. And for your information, Dr. Novi is the first Indonesian doctor to obtain both FIPP and CIPS in the first attempt. Next. She is a practicing pain physician at Prof. Dr. Ardi Kando Central General Hospital, or called Kando Pain Rehab Center, in the clinic. And she also practices at Bandung Pain Rehab Center and Peak Pain Rehab Clinic as a pain specialist. Next. She is a lecturer in Universitas Samratulangi for the Department of Physical Medicine and Rehabilitation, and she is also invited to many events, both international and national events. And this is you can see that in this picture, Dr. Novi was invited as a speaker in Sabah at the 18th Asian Federation of Sports Medicine Congress in Sabah in April 2024. Next. And she was also invited to the 77th scientific meeting of the Korean Pain Society to share her knowledge about low back pain. Next. Okay, this is her current event, our current event, cases and updates. And next, her upcoming event is at Pir Perdosri, Banten, Lampung, in the next 2 weeks about upper extremity rehabilitation updates. So if you would like to hear more about the topic and about Dr. Novi's presentation, please proceed to register yourself at the event. Next. For her academics, she is the lecturer and staff of PMR program at Faculty of Medicine, Universitas Samratulangi, and she is the program director of Pain Management Network. And she is also currently having an ongoing doctoral research on the OA pain, and also the editor of Journal of Indonesian PMR Associations. Next. She is active in many organizations, World Institute of Pain as the Secretary of Indonesian Section, and also the faculty and examiner on FIPP and CIPS credentials. And in Perdosri, she is the coordinator of IPM interest group. And then she is also the director of Indonesian chapter of International Society for MSK Ultrasound in Pain Medicine, director of WAPMU chapter Indonesia, and then she is also in the International Affairs Division for IASP chapter Indonesia, and also the co-founder and head of organizing committee of Perdini. Next. She is also a mom of two beautiful children, Arkitra Nura Hismayana. She is a Bachelor of Communication Science, and also Albert Rusli Susanto, which is currently having grade 11 at BPK Penabur Gading Serpong. BPK Penabur High School. And then she also has her own hobbies. She likes to run, she likes to do photography, and also her current hobby is diving. Okay, next. Our another faculty of pain management network is Dr. Dewa, Dewa Gede Satria Ambara Putra, orthopedic, Master of Biomedic and CIPS. He is the head of orthopedic department of Bali Med Hospital, Jembrana, Bali. He is also the chief of medical committee of the same hospital, and he is the board of scientific program in our pain management network. Next. He obtained his CIPS in Taiwan in 2023, and he also has his fellowship of comprehensive course in musculoskeletal pain intervention and regeneration. He obtained his orthopedic and traumatology specialist, and then Master of Biomedic and Medical Doctor from Universitas Udayana. And also, Dr. Dewa is a proud alumni of our program 3MLP Basic, Intermediate, and Advanced courses. Okay, next. As you can see, Dr. Dewa obtained his expertise in pain medicine from our programs in Pain Management Network in 2021. And he also had the CIPS at the 5th World Institute of Pain in Taipei Interventional Pain Workshop. Okay, so that's all about our faculty. And both Dr. Novi and Dr. Dewa are faculty of our routine program, 3-month learning program, USG Guided IPM. So last month, we just finished our 3MLP basic course, USG Guided IPM on musculoskeletal system, which was wrapped up with hands-on workshop on real patients. So before we get to the main topic of today's event about low back pain, we would like to invite the participants of our previous program to present cases from the workshop. Okay, the first, before we get to the cases, now let's say hi to our faculty first, Dr. Dewa and Dr. Novi. Good evening, Dr. Novi.
Hi, Dr. Chika, Dr. Dewa, good evening. And to you all, dear doctors at home.
How are you, Dr. Dewa?
Hello, fine. How are
Okay,
you?
how about you, Dr. Novi?
I'm fine too, thank you. How are you, Dr. Chika and Dr. Dewa?
I am fine, Doctor. I am very excited for today's event because not only Dr. Dewa and Dr. Novi who will present about low back pain, but first we would like to hear the presentations from our previous workshop about musculoskeletal pain management. And the first case is from group 1 with Dr. Deborah, Dr. Daryani, Dr. Nia, and Dr. Nur Izzati. So Dr. Dewa and Dr. Novi, are you ready to hear about the case?
Yes, sure. Please proceed.
Okay. So to Dr. Deborah Hendra, neurologist, are you ready to present the case for us?
Yes, Doc. Ready to present now.
Okay, good evening, doctor.
Hi, good evening, Dr. Maria. Good evening to Dr. Novi and Dr. Dewa, and also all the participants. Nice to finally meet you here online.
Okay, thank you, doctor. So let's just proceed with the PowerPoint file. Okay,
Okay,
you may proceed, doctor.
should I share the slide or do it? Okay, thank you, admin, for
Yes.
presenting the slide. So this is the first case that I work on the workshop. I work with Dr. Nia, Dr. Nur Izzati, and Dr. Daryani on this case. Next slide. So this case is about a patient is a business owner, which is a laundry business. Next, she presented on with shoulder pain since January. The pain is on the right shoulder, which is not radiated to the arms, and elicited while sleeping on a certain position, and it does not cause any numbness or tingling sensation. The pain alleviated when the patient rested on a certain position. The pain rating scale is quite high, which is 7 out of 10. So the patient have difficulty sleeping due to the pain, but it doesn't affect the appetite. The medical history of patient is hypertension and dyslipidemia. The patient does not have diabetes and do not take anticoagulant medication. The medical history of this patient, for the right shoulder, the patient already did a 6 injection within the 2 weeks interval at 4 points by specialist doctors. The patient said that the pain alleviated a little, but they but then the pain comes back after a few days. And the medication history is meloxicam 15 milligrams per day, which the patient do not take routinely. She only took the medication whenever the pain comes. The patient also did physiotherapy consisting microwave diathermy, TENS, exercise. Patient also put ice pack on the shoulder and also apply topical analgesics. Next. The physical examinations of the patient, when we look into the shoulder, we do not see any swelling or deformity. When we touch the shoulder, we also do not feel a hyperemia. And the sensory function of the shoulder and arms is also intact. When we move the shoulder, we have a slight reduction on abduction movement, and also a painful movement when we abduct the right shoulder, but we do not see any resistance or a pain in the on the left shoulder. We also see this when we flex the shoulder, the range of movement is still good, but the painful flexion we find it on the right shoulder only. When we do the internal and external rotation, the range of movement of the right shoulder is also decreased, but there is no motoric weakness on the arms. When we do special tests, we see a positive lift-off and irrigation test on the right shoulder only. Next. So based on the history and the physical examination, we make a few differential diagnoses, which in which our first differential diagnosis is the tendinitis of the biceps long head, And other differential is the tendinitis of the supraspinatus, bursitis of subacromial subdeltoid bursa, OA of glenohumeral joints, frozen shoulder, tendinitis subscapularis, and also impingement of the supraspinatus. Next. Yeah, and then we did an ultrasound scanning of the shoulder, and we find here along the, sorry, I hear an echo of the voice. Okay, and then I find here around the long head of the biceps tendon, we find effusion. So it's the pathology that we find during our scanning. Next. Yeah, and then we try to scan the other structure, the AC joints, the glenohumeral joints, and other structure. We do not see any specific pathology. So we are going to proceed with our first differential diagnosis, which is the biceps long head tendinitis. Next. 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 And then to further confirm our diagnosis, we are going to do the diagnostic block. We inject 1 milliliter of 1% lidocaine around the long head biceps tendon. And after the diagnostic block, we check again whether the patient range of movement and pain improved, and it did. The patient claimed that the pain improved, the shoulder flexion improved, as well as the other shoulder range of motion, which is abduction, internal and external rotation, in which previously was restricted. And we also did a repeat special test checking. We find the Yergason test is now negative. Next. So we are more affirmed that this is the correct diagnosis. So we proceed again with the IPM of injecting 2 cc of triamcinolone 20 milligrams around the peritendon of the long head biceps tendon. And after IPM, we see the range of movement is good, and the pain is reduced significantly. We also give the patient take-home medication, in which if the pain recurs, the patient can take paracetamols, and we also give the patient education. We advise the patient to reduce her shoulder activity for a few days, and then we plan for the patient to be evaluated in 2 weeks' time. So that was our first case. This is the vital sign post-IPM, quite stable. Thank you, everyone.
I made the right decision on 2021, attending 3 MLP advanced course ultrasound guided IPM on spinal system. It is not the same as a workshops and a webinar I used to attend. I can perform a spinal IPM after the course, adding more effective tools to help my patients. The 3 MLP Basics, Intermediate and Advanced course is sufficient to help me pass CIPS exam in only one stride. It is certified interventional pain sonologist, a fellow from World Institute of Pain. As a CIPS fellow, I want to share my knowledge and skills to other fellow doctors by facilitating PMN courses.
Thank you, Dr. Deborah, for the great presentation. It's very interesting. It's an interesting case of shoulder musculoskeletal pain. For those who are wondering why we are still discussing about musculoskeletal pain, it's because we just finished our previous program, 3MLP basic course on musculoskeletal system. And some of the musculoskeletal pain is also related, maybe related to spine system. So before we get to the main topic for today's event, spinal intervention for low back pain, we would like to discuss a little bit about musculoskeletal pain. Okay, so now let's discuss about the pain that was just presented by Dr. Deborah. We have about 10 minutes to discuss about the shoulder pain. And for those participants who would like to ask a question about the case, please proceed to write your questions in the Q&A or the chat box, and I will read the questions for you, or you can simply raise your hand and unmute yourself. Okay. So while we wait, maybe we would like to hear the comments from our faculty. Oh yeah, Doctor, for the participants, I would like to remind that for those who have the best questions and the most active participants, we will give you gift vouchers for our next program about 3MLP advanced course on spine. Okay, now let's hear the comments from Dr. Novi and Dr. Dewa about the presentation.
It's a very interesting case, Dr. Deborah, and you presented very nicely. I'd like to see the presentation. But I believe the audience have questions for you. Don't they, Dr. Chika?
Yes, I think we should wait for the participants to ask questions. And don't worry, because we have an interesting gift voucher for you to join our next program on spine. So in the seminar, this is the first segment of our webinar, in which the previous program, the 3MLP basic course on musculoskeletal, the participants presented musculoskeletal cases that can provide insight to all of us and introduced us as alumni of the programs from previous webinars and workshops. And after the cases presentation, we will explain about the cases that illustrate the importance of doctors understanding all of the components from musculoskeletal system, from peripheral nervous system, and also spine, which is the topics on our programs, basic, intermediate, and also advanced courses. Okay, so maybe while we wait for the comments and also the questions from our participants, we can continue to the second case presentation by Dr. Astrid, physiatrist. Okay, Dr. Deborah, we will continue the discussion after the second case presentation. Okay, Dr. Astrid, are you there?
Hello, Doc. Good evening.
Good evening, doctor. So, the second case is brought to you by Dr. Bona, Dr. Astrid, and also Dr. Hesti, and they named their group as Group Ceria. Ceria means cheerful in Bahasa Indonesia. So, let's hear the case from Group Ceria as the second case presentation. Okay, Dr. Astrid, can you see the slide already?
Yes, thank you.
Okay.
Okay, I will begin my presentation. Good evening to all the participants. Today I will present our case at our last workshop. So my group is there is me, Dr. Astrid, and Dr. Bona and Dr. Hesti, neurologist. Okay, next slide. From the identity, the patient is male, age 67 years old, and the occupation is pastor or priest. Next. From history taking, the chief complaint is pain on the left knee since 10 years ago at the side part. The pain is not radiating. Uh, ex- at that time, the pain is on both knee, but the patient feel pain at the left knee is worse than the right side. The pain feel especially when the patient moving, such as from sitting to standing. Uh, there is no waist pain and buttock pain. There is also pain at the morning and stiffness at the morning when the patient woke up, but less than 30 minutes. The pain and the stiffness is relieved and also by the activity. The pain is subside. When sitting, the patient didn't feel hurt, but when the patient began to stand and walk, the patient feel hurts at the knee. From the treatment of history, patient usually take allopurinol but without doctor prescription, and the patient said that the pain did not relieve. Next. From the history of disease, patient had diabetes, long-term diabetes, and there is no history of trauma. History of medication, patient usually take metformin, and usually patient can do usual activities such as housekeeping in his house. Next slide. From objective, from the vital sign, the blood pressure was 120/80, heart rate was 88 beat per minute, respiratory rate was 20, the saturation 98%, the temperature normal, and the numeral rating score is 4 to 5. Drugs is metformin. Patient takes drugs metformin 3 times daily. From the physical examination, from the objective, from the look, we can see there is genu valgus from the patient, and there is also reduce of knee extension, lack of extension on both knee. There is no sign of inflammation. From other observation, when we ask the patient to stand, we can see that the patient slightly bend to the left, to the right, because when we see the patient from observation, we can see the left shoulder is higher than the right side. And also we can see there is atrophy on the left quadriceps muscle. From the feel or palpation, we can feel the tenderness at the suprapatellar region. At the time we ask for the FAST on NRS, NRS, the patient said the pain is past 7. There is also tenderness on the left Jordis tubercle with NRS is 5, and also at the left LCL. But there is no sign of inflammation, but we can feel some crepitus on the both knee, especially on the left side. Right? And then from the range of motion, the patient can do flexion until 130 degree at both sides. But from the extension, there is some lack of extension. Actually, from the right side, there is minus 13, and from the left side is minus 51. So the left side is worse than the right side. The left side was more bending than the right side. Next. So from the history taking and physical examination, we came to some differential diagnosis. The first one, that is osteoarthritis of the knee. And then the second is bursitis of the knee, of suprapatellar of the knee. And the last one is because patient feel pain at the side, we conclude there is some iliotibial bend syndrome. And then the additional diagnosis is diabetes. Right? We do the laboratory test, and the random blood sugar is 250 milligram per deciliter. And then we do some diagnostic imaging tests with USG of musculoskeletal. There is we check for the suprapatellar region, that we can see that there is fluid collection at the suprapatellar bursa. Next. From the lateral at the left knee, we can from the medial, we can see the medial collateral ligament with the normal limit. Next. And the pes anserine is with the normal limit also, which we do the examination on the tenderness area, especially. Next. So our working diagnosis was osteoarthritis of the knee with suprapatellar effusion at the left side. With additional working diagnosis is diabetes. We do the treatment for the patient. First, we do the aspiration for the effusion, and then we inject the triamcinolone 30 milligram on the suprapatellar recess. Okay. Thank you. Any questions?
Hello, my name is Daniel Hadimartana and I'm physiatrist. I have already passed 3MLP, musculoskeletal and nervous system, and I'm looking forward to join the 3MLP advanced course, the spine system. And this is a rarely held course and I'm looking forward to learning. Not many specialists are capable of performing spinal pain management. And from the shortlist, not many are willing to spend time teaching others to become proficient. And TRMLP is indeed not a common webinar and not a common workshop. I develop my skills and knowledge in each 3-month learning program. And passing the advanced course will give me confidence in gaining local or international fellow programs in the future.
Okay, thank you very much, Dr. Astrid, for the great presentation. Now we
you.
are back to the discussion session for both case 1 and case 2. As we can see in the chat box, we already have a question from Dr. Ni Nyoman Tri Premani. Good evening. Dr. Ni Nyoman Tri Premani would like to ask, can we skip the injection of 1 cc lidocaine for workup diagnosis? Maybe the diagnostic block, I think. And then we just do the 1 injection with the combination of lidocaine and triamcinolone to 20 milligrams. Okay, Dr. Deborah.
Oh, here. So, may I try to answer about can we skip the diagnostic block? The answer is yes, if you are very sure about the location of the pathology. Meanwhile, in the previous case, we have a lot of differential diagnosis. And also the physical examination and the special test that we do, the sensitivity and the specificity is not too high. So therefore, we choose to do the diagnostic block first. But if you find another case which are very confirming about the site of the pathology, the diagnostic block sometimes is not necessary. So Dr. Novi and Dr. Dewa, you may correct me if I'm wrong.
Okay, thank you for the answer, Dr. Deborah, and thank you for the question, Dr. Ninyoman. Dr. Novi, would you like to add some comments?
Yes, Dr. Ninyoman. May I ask you back, why are you very sure that you want to inject the biceps tendon directly using the triamcinolone instead of the way that Dr. Deborah did? Dr. Ninyoman, are you there? Please feel free to open your camera and answer, or if you prefer to chat in the chat box, it's okay also. But I think it's better if we have an interactive way in doing this webinar.
Okay, Dr. Ninyoman, are you there?
Hello. Sorry, because I need to in the quiet space. I just see the scan of the shoulder in the long head bicep. There is an effusion, and there is the pathologic that we can work up that there is the tendinitis, because I think the patient feel pain when because they afraid about the injection.
Yes, thank you, Dr. Ninyaman.
Yeah.
Yes, it's very logic. So go back to Dr. Deborah. What's your answer then, Dr. Deborah?
So a diagnostic block does have some disadvantages. So a patient have to take 2 times of injection. If the patient is scared of needle, it will put twice the pressure for the patient. So
Ah.
if you if you are very sure about the pathology, you can just do it, do the therapeutic injection without diagnostic block first. But
Yes,
in
according to
this
Dr.
case,
Newman,
mhm,
according to Dr. Newman, she's very sure that the diagnosis is bicipital tendinosis. How about you? Why you are in doubt?
because like we also have like other side that maybe like osteoarthritis of the shoulder is also possible, and maybe if after we do the diagnostic block, if the pain is from other structure, maybe it will not improve very much. So we want to try the long head bicep tendon injection block first to make sure that the therapeutic agent injected to those sites will affect the pain significantly. Yeah, because
We
again,
see from the
effusion
we
is
see
not.
from the if we see the physical exam, is there anything that you can add more to Dr. Ninyoma about your reason why you want to do the diagnostic block first?
I don't know. Maybe we do a lift off test, and it is also positive. So other than irrigation, we do lift off test, and it also comes out positive. So maybe we suspect a pathology also in the subscapularis tendon. But then after we do diagnostic block, the pain completely gone. So we do not need to intervene on the subscapularis. Maybe there is one of
Okay.
the benefits of doing the block. So we do not
Yes,
do
I
like
agree with you.
Mhm.
Yeah, maybe Dr. Dewa want to add some more knowledge to this question and answers.
Yeah, thank you, Dr. Novi, and thank you, Dr. Nyoman. Dr. Nyoman, you are what specialist?
I'm the neurologist.
Neurology. You
Yeah.
work in Bali?
Yes,
What hospital?
I work Udayana Army Hospital.
Oh, yeah. Okay.
Yeah,
Yeah.
in Denpasar.
Yeah, thank you, Dr. Nyoman. Do
Yeah.
you already perform IPM injection in your daily practice?
Yes, I use yeah,
With ultrasound guiding, yeah?
with ultrasound scanning, with ultrasound guiding.
Yes. Yeah, thank you, Dr. Nyoman, for your question. Yeah, actually, the principle is if there's more than one differential diagnosis that we can establish from taking history and physical examination, we have to sure what is the more than one differential diagnosis is the pain generator that will make suffering most for the patients. Yeah, I think I agree with Dr. Deborah. Yeah, I think it's not problem with the patient if we educate the patient well. What is the aim of the injection in the first time, in the second time, because it will make the patient cure accurately if we can inject the pain generator properly. Yeah. So diagnosis block is one of the most effective of our tool we can perform directly to the patient. Yeah. If we have more than one differential diagnosis, of course. Yeah. I think I'm agree with Dr. Deborah. Yeah. And sometimes when you are facing with only one single diagnosis and you are very sure that this is the pain generator that will exist only with the patient, it is no problem if you do only single shoot injection. Yeah. But if not, I think it's better you do the diagnostic block. Yeah. You just inject the lidocaine and you evaluate the pain score and the ROM and the other examination. If more than 50%, this is correct. And you continue inject with the active preparat. Yeah. I think that's my answer, and thank you for the good question, for the good answer for the from the Dr. Deborah.
Okay. Thank you, doctor, for the Dr. Novi, Dr. Deborah, and also Dr. Dewa for the answers about the question. Okay, before we get to the question in the chat box, maybe we can proceed to the question by Dr. Dianti. Dr. Dianti YS, would you like to ask a question?
Yes.
Okay, good evening, doctor.
Good evening, Doc. Good evening, Dr. Novi. Good evening, Dr. Dewa. Sorry, I tried to type my questions in the chat, but I couldn't, so I raised my hands. I have two questions. One is for group 1 to Dr. Deborah. So based on the ultrasonography finding, you also found thickening of the bursae, if I'm not mistaken. Do you think even after the injection to the long head of biceps, do you think you should still do anything about the bursa? And for the second group, the patient has pain on pressure on his left pes anserin. And even though in the ultrasonographic finding, it didn't show anything, do you think there's anything that you could do about the patient's complaint? Thank you, doctor. That's all.
Okay, thank you very much, Dr. Dianti, for the question. Maybe we ask Dr. Deborah again. Did you hear the question clearly?
Yeah. Hi, Dr. Dianti.
Hi, Dr. Deborah.
Nice to meet you again.
Yes, very nice to
So,
meet you.
Thank you for the question. As we see, like in the physical examination, we have like a lot of abnormalities, so that we have a lot of differential diagnosis. And also in the ultrasound, we also find more than one pathological findings, in which like the bursa is slightly thickened also, but it is not very striking as the effusion around the long head biceps tendon. So I think the diagnostic block that we do here also plays a role in identifying the pain generator. As you can see that the ultrasound finding is not always not every abnormal findings is not always the main generator. Therefore, after we inject the lidocaine only to the long head biceps tendon, the function of the shoulder already resumed to normal. The range of movement already good, the pain score already low. So then we decide to just inject that structure, which we believe is the pain generator. And about the thickening of the bursae, not every pathological finding in our ultrasound needs to be managed by IPM. Maybe we can reduce the inflammation of the bursae by like medical oral medication, by resting, by cold compression, and other things. So maybe that is my explanation, Dr. Novi and Dr. Dewa. You may give me inputs.
Dr. Dewa first, maybe.
Yeah, thank you, Dr. Deborah. I think Dr. Deborah already have a good answer. Yeah, and the principle is we treat the patient, not treat the picture. We not treat the X-ray, we not treat the ultrasound, we not treat the MRI. Yeah, as long as you do the good taking history and physical examination, and then the ultrasound only can be your guiding to do the safety injection. But if accidentally you find something abnormality, yeah, you must connect with the physical examination that you find, yeah, not only the picture of your image. Yeah, I think that's all. Thank you, Dr. Novi, maybe.
Yes, I agree with you. And related to the that we may see sonopathology that is not connected to the clinical findings. What we must do is we stick to our clinical findings. According to Dr. Dianti's question, are we going to treat the bursae of SASD? For me, I will not, because after Dr. Deborah treated the biceps tendon, then the numerating rating scale becomes 0, right? Means that there's no pain anymore, means any diagnosis related to the ultrasound is nothing now, except if the pain, if the patient comes back and there's still complaint, and after taking history, taking and physical exam, and there's another diagnosis, then maybe we will treat the SASD if the diagnosis is SASD bursitis. If not, we will just leave the sonopathology there as it is without needed to be treated.
For the inputs, Dr. Novi, Dr. Dewa, and also Dr. Deborah for the great answers. Now we can see, we can proceed to the second question from Dr. Dianti to Dr. Astrid. Hello, Dr. Astrid. I will repeat the question. It's about the past answering. Before it was mentioned that the past answering, if I'm not mistaken, it has some tenderness when palpated, but the USG results was normal. So Dr. Dianti asked if we need to do something about the past answering pain.
Okay, thank you, doctor. I will try to answer. Actually, as I recall it, the pain was on the lateral side at the iliotibial band. So after we inject the triamcinolone, we asked for the FAS of the patient, and the patient said that the FAS is 0. He didn't feel any more pain. So we decide not to treat the tenderness side because all the pain is subside according to the patient. Thank you, doctor.
Okay, thank you, Dr. Astrid, for the answer. Dr. Dianti, would you like to ask more about the question? Or is the answer clear enough?
I think it's very clear. And thank you, doctor. Apologies, it's the ITB, doc, yeah, in the Gerdy's tubercle.
Yes. Thank
Okay,
you.
noted, doctor. Thank you very much. We can
Thank you,
probably
Dr. Dianti, for the questions, and Dr. Astrid for the answer. Now let's continue with the chat box questions from Dr. Rizky Ilona. Dr. Rizky would like to ask about the bursitis. So after the in some cases, after 2 weeks, the bursitis are still there. So how to prevent it? that the bursitis will not happen again. And for the second question is for knee OA, when is the best time or when is it indicated to give a hyaluronic acid? Okay, Dr. Astrid, you may answer.
Okay, thank you for the question. For the first question, yes, there is some cases that after we inject the triamcinolone, the bursitis will or the fluid will still appear. So usually, uh, uh, according to my opinion, according to my experience, usually I will, if there is any another fluid collection or the bursitis, I will give some medicamentosa, and then I will uh, ask for the patient if the diabetes is treatment well, because at this patient he had another uh, diagnosis, another comorbid is diabetes. And if there also I will do as a physical medicine and rehabilitation specialist, I will give him some rehabilitation program. And also maybe I will educate the patient to do some knee joint conservation. I will give him some knee support. So maybe it will uh, untuk mengurangi munculnya lagi atau mengurangi kemungkinan munculnya lagi bursitisnya. Okay. What is the second question, doctor?
The second question is when is it indicated to give hyaluronic acid for knee OA?
Okay. Please, Dr. Dewa and Dr. Novi, correct me if I'm wrong. Because this patient is also complain the stiffness, and there is from the physical examination we can we find there is crepitation. Actually, we can give the hyaluronic acid, but we can for my experience, I usually wait for the treatment to work, and I will assess. Usually, for me, usually I will wait for 1 week. So after that, I will give hyaluronic acid. Uh, for this patient, we supposed to give the hyaluronic acid because he had the symptoms is morning stiffness, and when walking and at the physical examination there is crepitation. I'm sorry for the first one juga. For the first question, if there is still another, but there is bursitis again to appear, so maybe we can look for the other structure of the knee. So we can assess another structure because the knee is such a complex joint. Maybe the collection, the fluid collection is from another structure, not from only the osteoarthritis. Thank you, doctor.
Okay, thank you, Dr. Astrid, for the answer. Maybe Dr. Novi would like to give some comments.
Yes, thank you, Dr. Astrid, for the very good presentation and for the question from Dr. Rizky. It's a very challenging question because we are facing a lot of knee pain patients every day, right? And the question is also asked by the patient, will there be any more fluid collection in my knees after it's been aspirated, right? It depends on quite a lot of circumstances, such as can the patient maintain the healthiness of the knee. Means that, as we know, the fluid collection can come from the overloading of the knee, right? If it is effusion in the suprapatellar bursa. So the patient should be asked to maintain the load to the knees. If the load is over, then the fluid collection can come back. And the second, if there's inflammation in the synovium, the fluid collection can come back again. So make sure that those aspects can be treated well and can be managed well. If then the fluid collection comes back again and again, it's wise to consult your patients to the orthopedist, to Dr. Dewa maybe, right, Dr. Dewa? How about your comment?
Yes, thank you, Dr. Novi. I'm very agree with Dr. Novi. Yeah. The first thing, what we do after we give injection to the patient is education. What is education means? Education is we give the patient educate what the patient can do, what the patient cannot do, what must the patient avoid. Yeah, and of course, what like Dr. Novi said, weight loading of the knee will produce more inflammation. So the patient must be avoid that. For example, in this case, the patient is pastor, yeah, and then patient is have must be serve the umat with a long standing in the church like that. Yeah, that must be educate to the patient how to manage the knee. Yeah, like that. And then when the patient already we give the education what patient can do and what patient cannot do and what must be avoided, but the effusion can come back again. Yeah, of course we must see the what is the other problem of the knee. Yeah, and beside the synovitis, of course, and sometimes in an elderly patient there is a degenerative process of the meniscus become a little bit tear. Yeah, little bit tear, then the meniscus will be like corpus alenum that will make the synovium produce again the effusion. Okay, and then of course if come and come again, what we can must do, we can help the patient by doing aspiration, of course, and then we can give prolotherapy and other regenerative treatment. But the underlying pathologies must be find out what if the cause of the recurrent of the effusion or bursitis. Yeah. Okay. And then this is a quite common case. After we aspirate, after we inject, and 2 weeks again, patient come again with a huge effusion like that. Yeah, this is a good question from Dr. Rizky. And then from what about the hyaluronic acid? Yeah, hyaluronic acid is others option that you can give. Yeah, of course, in this patient, after you give the injection like triamcinolone, you give a spare time for the triamcinolone works well. Yeah, if the patient still feel pain and you already give the education, you can do the next step with the AA or prolotherapy or PRP or other agent of regenerative treatment. Yeah, in my daily practice, I give 4 weeks after injection of the triamcinolone if the patient need to get hyaluronic acid. Yeah. Thank you very much. Thank you.
Thank you very much, Dr. Dewa, Dr. Novi. and Dr. Astrid, Dr. Deborah, and for the participants who actively asked questions about the case presentation. As we can see, our alumni from our programs have gained very much knowledge about the pain management, particularly from our previous program, basic course on musculoskeletal system. So this wraps up the previous program. But first, maybe Dr. Novi and Dr. Dewa would like to say congratulations to the alumni of the previous program.
Yes,
Then
congratulations to you all who has already passed the 3 months learning program of the musculoskeletal system using ultrasound guided interventional pain management. I'm very proud of you all, and I'm very proud of myself and Dr. Dewa as well, because we've finished the program, finished by us doing the cadaveric and real patient workshop last week, which is very successfully done. And I believe you all now can already manage your pain patient, especially musculoskeletal pain patients. Although in the last cases in the Tarumanagara University, we found not only the musculoskeletal pain patients, but also the nerve pain patients and spine pain patients. So that's why we conducted this program, the case and updates program, started by the MSK cases first, because one of the case, actually the knee cases, is related to the low back pain case, but it isn't mentioned by Dr. Astrid, but actually the pastor has low back pain also. So related to those cases, we'd like to open all of our minds to see that pain is not only musculoskeletal, pain can be comes from the nerve and spine. So we are here now. We'll continue with the spine cases, but hopefully you all has already mastered the MSK, and then if you then learn about the nerve and the spine, you can open your own pain clinic, not only your MSK. Congratulations.
congratulations.
Okay, what about Dr. Dewa? Would you like to give some advices to the alumni?
Yes. Once again, congratulations for the all doctors already joining the PMN for the 3 months and ending by our 2 days offline workshop. Yeah, and then very enthusiasm for all of you. And then I think learning is never stop. Learning is still continue along of our life. Yeah. So after you continue the MSK, yeah, there's still another program for the nerve and spine, and I same as you also, yeah, and then I follow all of the program and trust and believe it, and we can help and and treat the patient well with combined with this program. Thank you.
Okay, thank you, Dr. Dewa, Dr. Novi, and the faculty of our programs of Pain Management Networks programs. And once again, congratulations and good luck in your pain practice. And don't forget to join our next programs, intermediate and also advanced courses. Now, before we proceed to the next session, let's see the videos of the recap of our webinars and also workshop. Thank you for the videos, and once again, thank you for all of the participants of 3 MLP Basic Course UB07, and see you in our next programs. So, exactly what are the programs of Pain Management Network? I would like to introduce our programs. So, as you can see, we regularly have cases and updates uh, as like we are having right now. Cases and updates are events by Pain Management Network, which mostly are open to specialist doctors who would like to learn more about the updates on pain management, and also from the case presentations by our faculty and also our alumni. Next. Our nearest program is the 3 MLP Advanced Course Ultrasound Guided IPM on Spine System. This is a 3-month learning program from September to December, which includes 18 webinars and 2 hands-on workshops. So, in this course, you will learn about thoracic, lumbar, and cervical spine, and along with the spinal intervention for the pain. As the examples are caudal epidural injection, subarachnoid block, facet block, and many more. So this is also a very rare opportunity. This is our second course. The first course was in 2021, and we are having this in 2024, and our third program is planned in 2026. So I think you should not miss the opportunity to join this program in this year. And if you are interested, please do not hesitate to contact our administrator on WhatsApp or on our social media, Instagram or Facebook. Next. And as I have explained before, we have already had the 3 MLP basic course, ultrasound guided IPM on musculoskeletal system. Just last week, we have finished this program, and it is coming again soon in 2025. So please stay tuned on our social media. Next. We also have the intermediate course. This is on the peripheral nervous system. And we will also have this program again in 2025. So if you are interested, if you have finished the basic course and would like to continue more to learn about pain management, please stay tuned on our social media for updates about the intermediate course. Next. Okay, so if you have colleagues or friends who are non-interventional physicians or general practitioners, but they want to learn more about pain management, the non-interventional treatments, you can suggest them to join the 4NIP or pain management for non-interventional physicians. This is a 4-week programs with 10 webinars, which includes pain management learning programs that is non-interventional, but it is a very comprehensive learning program. So it is also coming soon in the next year. Next. And we also have short courses. It is called SCORE. Short course overview and refreshment of education by Pain Management Network. In this short courses, we have special topics which are selected based on the prevalence of the pain cases that you can see in your practices. And we are coming soon in the next year with more interesting topics. As you can see, the previous topics were knee and shoulder IPM, along with the prolotherapy, BRP, and RF procedures. Next. Okay, so Dr. Novi, she is also an author of the book. It is called Handbook of Ultrasound Guided Interventional Pain Management on Musculoskeletal System Standard Proficiency. So while you wait for the 3 MLP basic course in the next year, you can buy this book. It is in ready stock. And if you would like to learn more, you can simply order and contact our administrator through email or through WhatsApp, and we will directly send the book to your address. Okay, so that's all about our programs. So I think we already have very many participants joining us from around the world, from Indonesia, from India, Turkey, the Philippines, US, Germany, if I'm not mistaken. So I think we should take a picture first with the participants. Please turn on your cameras so we can take a picture together in today's event. Okay, hello Dr. Deborah, hello again. Okay, Dr. Astrid, Dr. Dewa, Maybe Dr. Dianti, Dr. Ninyoman, Dr. Isha. Okay, hello Dr. Auli, Dr. Ninyoman, Dr. Mutia, Dr. Irene. Okay, hello Dr. Lina, Dr. Muhtar. Okay. 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 Yeah. In Okay, hello Dr. Cynthia.
Hi, doctor.
Hello doctors. Okay. So let's have a picture together in 1, 2, 3. Okay. One more time. In 1, 2, 3. Okay. Oh, okay. Hello, Dr. Adiba. Let's have it one more time. Okay. 1, 2, 3. Okay. Thank you, doctors, for the pictures. So, as I have explained, our nearest program is the 3 MLP Advanced course on spine. And this is the main topic for today's event, spinal intervention for low back pain. And in this in the next case presentations, we would like to introduce the examples of the cases that can be treated by spinal intervention or other modalities for pain management. Okay. First, Dr. Novi would like to present 3 cases. The 3 cases are represent a spectrum of various cases of low back pain with various treatments too. So, Dr. Novi, are you ready to present the case?
Sure. May I?
Okay.
Okay.
Let's proceed the case.
Okay, thank you, Dr. Jessica. Dear doctors, Dr. Jessica is a very talented doctor in PMN program, besides of Dr. Salsa and Dr. Lina here. And they are all available, right? So you can just text me, okay? Okay, back to the topic about the low back pain. I have 3 cases actually, but actually I have only a very short time, 30 minutes. So actually I don't want to talk about it into a detailed manner, but I want to emphasize on this step ladder of pain management, where starting from the case from Dr. Deborah and Dr. Astrid, the Ceria group, we all can see that they treated the patient using interventional pain management. But actually, we should start from the lowest stair, which is non-pharmacological method, and continue with non-opioid, weak opioid, strong opioid, as the indication is needed by the patient. And we can add some more adjuvants non-steroidal anti-inflammatory medication. And then if the pain is still there for 1 month for myself, I will think about, is there any other treatment instead of the conservative, rehabilitative, and medicamentous treatment to make the pain off the patients before the surgery is indicated to treat the pain, which is IPM or interventional pain management, to make the pain is cured, means there's recovery of the patients and recover from the function. That is the goal of all of our pain treatment. So I'd like to show 3 cases. The first case is just maybe you meet these cases in your clinical settings. Happens to a 40 years old female who is housewife and is a master of ceremony whose complaint is back pain since 1 year. She has history of wearing high heels, and because of the low back pain, he cannot sit, he cannot standing from sitting without any pain, but there's no numbness, no tingling sensation, and he has never taken any medication. The orthopedist said that she has disc herniations, and the orthopedist gave her oral medications, and there's some improvement, but there's still some pain. The patient is delivered to the physical therapy department, to the rehab department, but she doesn't want to do it. So she came with still some pain with the numeric rating scale of 4 until 6. From the physical examination, the vital sign is quite normal and she is overweight. In the physical examination, there's no clear sign of pain in the lower back. Sitting, standing, walking has no pain. The range of motion of the back shows no pain also, but there's tenderness at the left piriformis muscle and the left sacroiliac joint. The special test for lower back pain were negative, all was negative. And when she's provoked with William flexion exercise, there's improvement of the lower back pain. From the physical examination of the neurological examination, the motoric function is 5 and the sensory is quite normal. So the differential diagnosis is piriformis muscle syndrome and sacroiliac joint arthropathy, and she is given physical therapy only, deep heating followed by TENS, and the numeric rating scale becomes 0, and followed by giving exercise to her. The numeric rating scale still 0, so the patient is given physical therapy once a week, and she's quite well. So this is the first case where low back pain can be treated using only a conservative rehabilitative treatment, although the patient has already suffered for the pain for 1 year. So if you think that the patient has already been in a chronic stage and you want to give the interventional pain management, this is the case. You can follow the way of thinking how the patient can be cured using only rehab. The second case is a female, 55 years old, who is a housewife. Again, complained of lower back pain and thigh pain radiating to the right leg since 8 months. And she came using wheelchair. She cannot sleep well, and because of the pain, she feels discomfort of the lateral right decubitus position, and she has also hyperuricemia and has already taken vitamin, painkiller, and muscle relaxants from the previous doctors. And actually, because the pain is 9/10 at the time, it is quite hard for our team to make history taking and physical exam at that time. She has already visited a lot of doctors, has already visited general practitioners, and she is said to have neuropathic pain, and she got vitamins and muscle relaxant. And because there's no improvement, she visits some neurologists, and they said that she has radiculopathy, and she's advised to have physical therapy, including TENS, acupuncture, and hydrotherapy, but there's no improvement at all. And so the neurologist referred her to a neurosurgeon who said that she has radiculopathy, and she is advised to have surgery, but she refused the surgery, and she visits another neurologist and is going to have some injections to the spine. But then, because of one another thing, the doctor cannot perform the injection. She came to our clinic, and from the physical examination, the vital sign, the blood pressure is a bit high, and the height and the weight is normal. Normal weight means, and from the another physical exam, while in sitting position, there's no pain. While standing, there's pain on right buttock and thigh. And when she walks, there's pain on the right buttock and thigh. Flexion cannot be evaluated. There's no pain in extension, right band, right rotation, and left rotation. There's tenderness on the right piriformis muscle. When in supine position, there's pain on the right thigh. The turning to the right and turning to the left cannot be evaluated, and also prone cannot be evaluated. The spatial test, the last sec on the right side is positive, Dragat positive also, Thomas positive. Patrick contrapatrick cannot be evaluated because of pain, and provocation using exercise cannot be evaluated also because of pain. The neurologic examinations result is there's reduction in sensory in L2 especially, and L3 till S1 only 9/10, and the strength of the L2 until S1 is 2 till 3/5. When I saw her, there's slight leg length discrepancy about 2 centimeter. So I was thinking at the time about neck femoral fracture. And because there's a reduction in sensory and motoric in L2 and S1, there's another diagnosis of suspect right lumbosacral radiculopathy, but should be assured after the pain has already reduced. So I asked about the previous supporting examination of the X-ray, because the patient has already visited a lot of doctors, and the result of the pelvic radiograph is there is elongation of coccyx to the anterior side and no clear lytic or sclerotic lesions at the bones, but there's suspected fracture of os coccyx. No fracture on the femur. But if we see here at the right side, I think it's a bit different, right? But let's ask Dr. Dewa after this. this right side and this left side, but not because I see the differences in the left and right humeral head. I asked for newest X-ray of the pelvis. This is the MRI, and it's quite normal also. So the differential diagnosis becomes fracture of coccyx bone and the previous differential diagnosis. And because she was in severe pain, we gave her infusion using dextrose and ketorolac. And before the ketorolac injection, we gave her ranitidine and neurobion and order for blood laboratory examination and pelvic plane radiography. The result of the laboratory exam is hyperuricemia. And this is the plain radiography at that time. You can see here this old complete fragmented fracture of the right femoral neck. And it seems that it is a pathological fracture. So the working diagnosis is fracture of right neck femur. And before she could finish or she could visit the orthopedic surgeon, we gave her NSAID, epirison, and tramadol with paracetamol and PPI. So in this case, although we see that the patient has already got normal MRI, quite normal plain radiography, if we relate to the physical exam, we know that there's something wrong, which a lot of doctors cannot see. So always take the patients as a new case, although the patient has already got a lot of examination and already visited a lot of doctors and already planned to do surgery or any kind of injections. Do not follow the other doctors, just face the patient as your own new patients. Okay, so this is not our case, this is the orthopedic case or the brain surgeon case. So just refer the patient to the surgeon. And then the third case is the case of a 40 years old boy who suffered for lower back pain since 3 months after falling while he did running and taekwondo. He can sit and standing, but in pain, and he can only do his prayer on chair and can climb stairs to go to the class for school, but in pain. He hasn't get any medication. No, sorry. He has already visited doctors and has already given dextromethorphan and methylprednisolone, and is already been tapering off in the methylprednisolone and has already physical therapy using TENS and deep heating without any significant improvement. In the physical examination, it is found that the consciousness is normal, the vital sign is normal, and he's overweight. While sitting, there's no pain, standing pain on the left lower back, walking no pain. There's pain on flexion but reduced in extension, left bend and rotation pain but not as painful as flexion. There's tenderness over the left sacroiliac joint, and the special test for the lower back were negative except for hip extension, painful on the both side. Provoked with exercise, there's no pain. The neurologic examinations is quite normal except for the left L3, the sensory only 9/10. The plain pelvic radiograph, there's constricted intervertebral foramen L5 and S1 and curved lordosis over the lumbar vertebrae. The ultrasound examination taken for the piriformis muscles are normal, and the sacroiliac joint is normal also. So the differential diagnosis is left sacroiliac joint arthropathy and left piriformis muscle syndrome. And because the finding of the piriformis muscle is quite normal, so the treatment, because it is already been chronic, is ultrasound guided interventional pain management on the left sacroiliac joint. And after the IPM, the numerating rating scale becomes 0. And afterwards, he was given tramadol and paracetamol only, added by eperisone and mecobalamin. So that's the third case that need to be treated using IPM. So I have 3 cases. The first case is treated well using conservative rehabilitation and then medicamentoous treatment. The second case is referred to the surgeon because then it is not a low back pain case, but fracture case of the femur. And the third case, although he's still young, I gave him IPM because it's already been 3 months and no improvement, although she has already taken the conservative, rehabilitative, and medicamentoous treatment in adequate status. So the take-home message is that please take a sharp diagnosis. The second is we must be able to take the diagnosis also, and the third is still diagnosis, so we can give the patient the adequate treatment and the precise treatment as indicated, not only IPM, because IPM is not a panacea. It's just a small part of the holistic rehabilitation program, not because I'm a rehab doctor, but because we need rehab since we were born until we go back. Okay, that's my third case. If you have any question, please feel free to ask. Thank you, Dr.
Okay.
Jessica.
Thank you very much, Dr. Novi, for the presentation. I think it is a very interesting presentation because Dr. Novi said that I think the most important skill for pain physicians is how to select, how to choose the appropriate treatments for the appropriate patients. Yeah, because the 3 cases actually are all low back pain, but in fact, the 3 cases need 3 different treatments. Okay, so thank you very much once again, Dr. Novi. And before we get to the discussion session, I think we should proceed with the presentation by Dr. Dewa first. Okay, Dr. Dewa will present 2 cases about low back pain, the lumbar facet arthropathy and the lumbar myofacial pain. Dr. Dewa, are you ready to present your cases?
Yes, of course, Dr. Jika.
Okay. Please proceed with the PowerPoint. Okay.
Okay. Good evening, all participants. Okay. Continue to the next case. Next slide. Okay, this is a male, 62 years old farmer, and he came with low back pain in the right side. Next. Okay. This pain is sharp and tightness pain in the right back within 6 months and getting worse months and weeks by weeks. Yeah. Patient in standing, feel pain, walking, pain, and sitting, little bit pain, and feel better when lying. When standing, patient feel if we confirm to the numeric rating scale is like 5 and 6, yeah. But when walking, it's getting worse to 7, yeah. The pain it's come from the back, but it's already radiated to the right buttock and back of the thigh in the right one, yeah. No numbness and no tingling sensation. Next. No past illness and patient already took many medication from the other doctors. Next. Okay. From the taking history, yeah, there's some differential diagnosis, yeah, that can be happen when the patient feel low back pain and radiated to the buttock and to the uh, posterior of the thigh, such as facet problem, and then radicular pain from the lumbar, joint arthropathy, piriformis syndrome, or even myofacial pain syndrome in the lumbar area because there are so many muscle attached there. Okay, next. The vital sign is normal. Next. Okay. To make diagnosis become sharp and to exclude some diagnosis to become the clinical assessment, is supposed to check for the physical examination, yeah, from the back and hip, yeah. When the patient sitting, patient feel okay, yeah. That's mean not too pain when sitting, but from sitting to stand, patient feel pain, and when walking, patient feel pain, yeah. And then from the range of motion of the lumbar, yeah, flexion, a little bit pain, but when the patient do the extension of the back, the pain is getting worse in the right side, yeah. And patient when they're rolling, yeah, like a rotation to the right side, pain getting worse. Next. There is a specifically finding from the patient. There is a tenderness in the paraspinal area just next lateral to the spinosus processus spinosus, yeah, and actually in the level of the iliac wing and the below, yeah. When he performed the facet loading test, this is positive in the right side, in the same place when I did the pressure to the paraspinal area. Motoric and sensoric is quite normal. SLR is negative, and then Faber test negative, and other test is negative also. Next. So the diagnosis become sharp to the lumbar facet arthropathy, and according to the location of the tenderness, yeah, it's supposed to be in the L4, L5, and L5S1 in the right side, yeah. And then patient, I order to the X-ray of the lumbar sacra, yeah, and the result is there's the spondylosis, yeah, you can see in the X-ray, and there is also the scoliosis, yeah, but this is, I think, de novo, yeah, because due to degenerative problem, yeah. And I ordered the X-ray to exclude the red flags. And sometimes for the patient have low back pain problem, yeah, and many cases I find patient also with spondylitis TB, yeah. So I do the X-ray to exclude the red flags for this patient. Next. Yeah. Before I do the IPM, yeah, I do the diagnostic block to confirm. First, I confirm the diagnosis that I made. The second, I do the diagnostic block to confirm the location of the pathologic, because there's so many facets, yeah, in the back, yeah. What is the most pain generator of the back, yeah? And then the result of the diagnostic block is patient show there's a reduction of the pain when I push, when I do the palpation, and then when the patient doing a range of motion of the lumbar. And then I continue to do the IPM and medial branch block in the L5, L4, L5 in S1 with dexamethasone and lignocaine 1%, 1 cc every level. And then I continue patient with the paracetamol and epirezole for the muscle spasm. Patient is give the education, yeah, and then the physical therapy also. Next. This is just resume like anatomy facet of the lumbar, yeah. There's the many facet there, and this is mobile joint, like a synovial joint that can 15 until 40% problem of the low back pain can come from this area. And this facet joint itself is innervated by the medial branch that come from the posterior rami of the lumbar. And every facet is innervated by the medial branch one level up and in the same level. For example, L4 and 5 is innervated by L3 and L4 of the lumbar. So the location of the injection of the medial branch is the junction. You can see in the picture in the right side is the junction between SAP and the transfer and the processus transversus in the junction between them. Yeah, and if you rotate the probe, become the long axis, you can see the position of the needle must be in the 1/3 of in the proximal of the processus. Next slide. Okay. After I perform the IPM, yeah, NSR is become 0 to 1, and vital sign is normal, and patient can perform rate of motion normally. Yeah. Okay. Next slide. Okay. Patient come again to our clinic after 1 month with the same problem, and then I decided to do the physical therapy. I refer to the rehabs doctor, and then continue the oral medication, and I combine with the spinal prolotherapy about 1 month. Okay, next. And after 1 month, there is no improvement significantly of this patient with this pain and with this rate of motion, and the pain is disturbing of the daily activity. Mostly this patient is farmer, yeah. Patient is still need go to the warm, yeah, to the rice field, yeah. And then I decided to do the radiofrequency ablation, yeah, to the medial branch, the same position that I do the IPM, yeah. But now the target is the medial branch itself from the L4, L5, and S1. You can see in the picture, yeah. In the right one, I perform in the L4 and L5, and the left one, the picture is L5 and S1, yeah. Okay, next slide. Okay, this is frame, yeah, that's can be our frame of thinking when we facing with a patient with a low back pain, yeah, must be first roll out of the red flags, yeah, like infection, tumor, or trauma, like something, yeah. Okay, next slide. Okay, after RF procedure, NR fast score is become 1, vital sign is normal, and ROM is getting normal. And post 1 week evaluation, there's no pain in standing, sitting, and patient could go to the farm. And after 3 month evaluation, patient can walk in farm. Yeah. And then this is some of the journal that I insert. This one can be our reference, yeah, to do the step ladder of the uh, treatment when we facing with patient of the facet joint problem. Of course, IPM is not everything. The treatment must be do the simultaneously from the education, physiotherapy, medical, and also IPM. Yeah. In this journal say that you can do the medial branch block first. Yeah. If all of the other conservative modality is uh, given a suboptimal result, and then if there's still pain, yeah, if there's still pain, we can go to the radiofrequency treatment as a gold standard based on this journal. And the evidence base is 1B plus. There is a positive recommendation. Okay, next slide. Okay. Now, other case, next slide. Okay, this is 52 years old. Patient occupation is farmer again. And chief complaint is low back pain in the left side. Next slide. She's feel shock and tightness in the left back since 4 months and getting worse. Yeah, pain when over in the bed and enable bear to pain and stand up upright and walking. Coughing and sneezing is painful, and pain is radiating to the left buttock, back, outer side of the thigh, and in front to the stomach. Okay, and NSR is 5 until 7. Sometimes wake up in the night. There's no numbness. There's no tingling sensation. Next slide. Okay, patient already got medication. Yeah, almost 4 months, and also physical therapy, but give a suboptimal outcome. Next slide. Okay, this is this same differential diagnosis that we need to exclude one by physical examination. Next slide. Okay, vital sign is normal. Next slide. Okay, patient feel pain in every position, yeah, from sitting, standing, and walking, and also every position when range of motion of the lumbar when flexing, extension, rolling to the right side and the left side, and the pain is in the little bit in the lateral to the paraspinal in the flank area. Next slide. Okay, when I did the palpation, the point of tenderness feel in the lateral of the paraspinal. Yeah, in the last case in the paraspinal tenderness, and in this case, a quite bit lateral to the paraspinal in the level of 5 finger breadth proximal to dorsal iliac wing. And motoric and sensoric is normal. In other tests like SLRs, Braga, and others tests is negative. You can see the pattern of the pain in the picture is in the lateral of the paraspinal and radiating to the buttock and to the front of the hip. Slide next. Yeah, I diagnosed this patient with myofacial pain syndrome of the lumbar. Yeah, with the differential diagnosis is the quadratus lumborum problem or erector spinal problem. So because both of these muscle is by next side by side, yeah. So I perform a diagnostic block with lidocaine 1 cc until 2 cc, and I inject to the intramuscular of the quadratus lumborum, and then pain reduce at least 50% while active range of motion. Next slide. And then I continue to give a triamcinolone 30 milligrams with the lidocaine, a total of the volume 6 cc. I do the injection inside of the quadratus lumborum intramuscular 3 cc, and then to the thoracolumbar fascia about 3 cc. And then patient give oral medication and physical therapy and also education. Next slide. Next slide, please. Yeah. This is anatomy of the muscle around of the lumbar. Yeah. There's a most big muscle is erector spinal muscle that makes the our lumbar become erect, and then the next to the lateral there is a quadratus lumborum, and this function is to flexion to the left or to the right side of the lumbar. Yeah. So next slide. Please come previously slide. Sorry. Previous slide. Okay, thank you. In the right one, in the right of the picture, yeah, you can see there is a TP is a transverse process, yeah, processus transversus, yeah. This location of this muscle, there is a between of erector spinal and psoas major, yeah. There is a very thin muscle, yeah, very tipis, yeah, thin, but this like little bit go to the come from the iliac to the 12 of the costa. Yeah, and this picture of the ultrasound is the short axis. Yeah, so must be careful to do injection to this because below this muscle there is a peritoneum. Okay, so I perform injection inside the muscle 3 cc and then to the thoracolumbar fascia, yeah, like in the narrow, like the arrow, yeah, about 3 cc. Next slide. Yeah. Post IPM, patient feel very reduction of the pain and range of motion of the lumbar become normal. And then next slide. Yeah. So we must think about all of the lumbar problem is not only connected to the spinal problem. Yeah, spinal mean there is a facet, disc, nerve root in other structure, but there is the big muscle, and this muscle it can be the source of the pain, can be the pain generator. So the taking history and the physical examination, like Dr. Novi said, diagnosis, and diagnosis very important to establish the sharp diagnosis. Yeah. So this patient is only have the problem of myofacial pain. Yeah, that can be treated well by the IPN. Yeah, because patient already chronically and already have other conservative treatment, but still get suboptimal result. Next slide. So if you are curious about how to establish the diagnosis of the spine from cervical, thoracic, lumbar, and how to do the facet injection, medial branch injection, how to do the RF radiofrequency, or how to scan the quadratus lumborum. This is a common pain generator in the lumbar that's commonly overlooked. Yeah. How to do the quadratus lumborum injection guiding USG. Please see the next slide, please. You can join with the program on the 3MLP spine system. Yeah. Next slide. Okay, thank you very much.
Okay, thank you very much, Dr. Dewa, for the presentation. Dr. Novi, also thank you. We have gained very much knowledge about low back pain and treatments for low back pain, starting from physiotherapy and exercise as non-pharmacology therapy. And then we saw the case that should be referred to the orthopedic surgeon, and then sacroiliac joint block, and then the spinal interventions that were presented by Dr. Dewa. Okay, so we are open for discussion right now. For participants who would like to ask a question to Dr. Novi or Dr. Dewa, please proceed to write your questions in the chat box, or raise your hand if you would like to unmute yourself and ask the question directly. Or Dr. Novi, would you like to add some comments to the cases presented by Dr. Dewa? Or maybe Dr. Dewa first. Would you like to add some inputs about the cases presented by Dr. Novi? If I'm not mistaken, Dr. Novi asked an opinion from Dr. Dewa about the
second case.
Yes, the second case, the fracture of the right neck femur case.
Yes. Yes.
Would you like to comment about it?
Yeah. Dr. Novi is my mentor, yeah. I think I learned Dr. Novi about pain and way to thinking. And I'm very agree with Dr. Novi. Although this patient come with already shopping doctor, so many get many treatment, see this patient with the new cases like this, yeah. Only see the small thing, like when you see the length different LLD, yeah. So we can make this diagnosis become clearly, yeah. And then so the treatment can given correctly by refer to the orthopedic, or Dr. Novi can find actually what is the main problem of this patient like this. Yeah, I think this is my opinion. Thank you.
Okay, thank you, Dr. Dewa.
Thank you, Dr. Dewa.
Okay, we have one question from Dr. Kelvin Yuanda to Dr. Novi. Can we do PENG block for case number 2 to reduce the pain before we refer to the orthopedic surgeon? Thank you, doctor.
Thank you, Dr. Kelvin. Yes, sure, of course, but the patient has already suffered for the pain for such a long time, for 8 months, 9 months, and she seems to be adapted to the pain, although the pain is so severe, and I don't want to give the patient something that is not usual actually, because I want the patient to see the orthopedics as soon as possible. If the pain has already reduced the by doing the pain block, I'm afraid the patient will not visit the orthopedist as soon as possible. So that's why I let the patient to feel some more pain to make her feel urgent to visit the orthopedist. But if the surgery is not the option after she visit the orthopedist, the pain block is one of the option to help the patient get some rid of the pain. Dr. Kelvin, that's my opinion. How about you, Dr. Dewa? Maybe you have other opinion.
Yes, I'm very agree with Dr. Novi. Yeah, because the root problem of this patient is fracture. Yeah, the pain is come from this fracture, so the fracture must be treated. Yeah, with the surgery, and then according to the Dr. Kevin, pen blocks. Yeah, pen block is the block to the anterior hip joint capsule. Yeah, it can be performed with the hip pain mostly in the anterior side. Yeah, and then I agree with Dr. Novi. If some patient with contraindication with the surgery, such as patient refuse it or patient have very many comorbidity of this patient, and surgery it's not safe to perform. Pen block is one of the option in this situation, like to reduce the pain and make the patient get comfort temporarily. Thank you.
Okay, thank you, Dr. Novi and Dr. Dewa, for the answers. To Dr. Kelvin, is it clear enough, or would you like to clarify more about the questions? While we wait, we have Dr. Rizky Ilona asking about how about the effectiveness of dry needling versus lidocaine injection for myofacial pain for the second case from Dr. Dewa. I'm sorry, Doc. You are still on mute.
Yeah, sorry. The question is dry needling for the myofacial pain, right?
Yes, versus or compared to lidocaine injection for myofascial pain.
Yeah. Actually, I never performed dry needling, yeah, from the myofascial pain, and I have no experience about dry needling. Yeah, when I facing with patient with myofascial pain syndrome, yeah, I always perform the conservative treatment first, like physical therapy and medication. Yeah, of course, sometimes, yeah, myofascial pain syndrome, yeah, can be primary and the secondary. Yeah, if there is a primary, is the root problem is the uh, muscle itself. Yeah, but if there is secondary, the myofascial pain syndrome is come from the other pathologies. This must be ruled out. Yeah. So regarding to the question, uh, to comparison about dry needling and IPM, I have no experience about dry needling, so I cannot answer that. Maybe Dr. Novi can give our insight about dry needling.
Okay, thank you, Dr. Dewa, for the answer. Yes, I think Dr. Novi should answer about the question because Dr. Novi regularly practices both dry needling and also spinal intervention in her clinic.
Okay, thank you.
Dr. Rizky.
Okay, about the dry needling, actually related to the name, it means that we insert needles to the some part of the patient's body without giving any medications into the body through the needle. It is aimed to make interference to the local electric uh, stability in the patient's body. By doing so, we hope that the pain will reduce by uh, one way is increasing blood flow to the site where the needle is inserted. And the second is making the muscles become more relaxed. And the third, by doing the needle insertion, it will trigger the brain to release endorphin that will cause pain reduction. So by inserting the needle, we hope that the muscle will be more relaxed, the blood flow will increasing, so the juice of inflammation there will enter the blood vessels to be delivered elsewhere. Then the inflammation will be reduced and the pain will be reduced, and the endorphin will be released by the brain, so the pain will be decreasing more. That's what I know about the dry needling. But if we add some more point of acupuncture points to the dry needling, the pain reduction will be even more. So if you are interested in doing dry needling and or acupuncture, it will do good for the pain patient, especially if the pain is related to the muscles, such as myofacial trigger point syndrome.
Thank you, Dr. Novi, for the answer. Also, Dr. Dewa for the answer about dry needling. We have another question from Dr. Wiko Hartantri. Thank you for the comprehensive explanation and case, Dr. Novi and Dr. Dewa. I'm still a novice about IPM. I would like to ask for older adult patients with back pain. They often come with degenerative spinal deformity such as scoliosis. What are the precautions of doing IPM as the anatomical positions of the bones and also the muscles might not be in the typical position? And the preferred techniques for such patients. What are the preferred techniques for such patients? Okay, so Dr. Dewa, can you please answer first? As you also mentioned about de novo scoliosis from the patients in the cases.
Yeah,
What are the precautions?
yeah. Thank you, Dr. Wiku. I think your answer is you supposed to follow the 3 MLP spine in this month. No, just kidding. But seriously,
Yes,
okay, seriously.
to be
Uh,
sure.
okay. Dr. Wiku, I think uh, about the anatomical changing regarding to the degenerative problem, of course, will make our solar anatomy also change. That's why you have to very familiar with the normal anatomical uh, appearance first, yeah, from the anatomy or the sono anatomy. Master and the sono anatomy of the normal spine, and then learn and practice. And then I think if you're facing with the problem with the degenerative pain, I think you can handle this one. Yeah, actually, there's no special precaution is this situation, but you have to know what is the dangers when you perform the spinal procedure, especially in the lumbar area, because when you facing with degenerative problem, yeah, the anatomical will be changed, doctor. Yeah, so yes, as I mentioned, I think you can follow the spine course that will give you very comprehensive uh, learning from the anatomical, anatomy, diagnosis, everything. Yeah, I think that's my answer. Yeah, thank you.
Thank you, Dr.
Dr. Novi.
Dewa, for the answer. Dr. Novi, do you have any opinions about the question? It is about for older patients with spinal deformity, such as de novo scoliosis. What are the precautions and the preferred techniques?
Yes, absolutely agree that the Dewa, you should attend the 3MLP for spine. Yeah, actually, if we already mastered the spine ultrasonography, especially ultrasound guided interventional pain management, we don't need to be too confused about the malalignment of the spine, etc., because we can see the spine itself using the ultrasound. Of course, it's not as easy as MSK or even nerve, but we can if we practice.
Okay, thank you, Dr. Novi, for the answer. Another question from Dr. Kelvin to Dr. Dewa. If we don't have radio frequency, can you give us other recommendations, or do you have an experience using chemical neurolysis for medial branch block? Dr. Dewa, I'm sorry, you're still on mute.
Oh, sorry. Yeah, there's so many way to perform a nerve ablation. Yeah, you can use a heat by radio frequency, and you can use a chemical, of course. From the chemical neurolysis, you can use the alcohol 90% or phenol. Yeah, but in the spine, it's very dangerous to use chemical neurolysis. Yeah, because the liquid that you inject, yeah, can be spreading to the other area. Yeah. In the medial branch, the location of the medial branch is between SAP and the processus transversus. Yeah. Uh, in this area, yeah, in this area is nearby with the foramina that nerve root come out. Yeah. That's why if you perform a chemical neurolysis, can be very dangerous in this case. Yeah. But if you don't have radio frequency ablation, what we can supposed to do to help the patient? Of course, you can do the medial branch injection and collaboration with the other treatment like physical therapy, or even you can do the spinal prolotherapy. If you never hear the spinal prolotherapy, what is that? What is the target of injection? We will explain you clearly in the program of the spine. Yeah. So RF is the last option. Yeah. I give you that case to give insight. There's a many step in IPM you can perform to help the patient. Yeah. Chemical neurolysis can be performed in other area that little a bit safe, like in the hip, a little bit like a pang, or in the shoulder. Yeah, but in the spine is quite dangerous. Thank you. Please, Dr. Novi can give us insight.
Okay.
Yes. Thank you, Dr. Dewa. I just only want to add that if we do radio frequency to the medial branch, we still reserve the motoric function actually. But if we do neurolysis, we destroy the nerve. So we only do phenol or alcohol neurolysis to a structure that is not needed anymore, or we need it for a short term only. For example, if we have pancreatic cancer pain patient and we need to do neurolysis to the celiac plexus or to the splanchnic ganglion, it's okay in the term of maybe the patient will go away, will pass away in 2 or 3 or 4, 5 months later on, it's okay. But for treating facet joint pain, as long as we can enter the facet joint itself, it's the best choice actually. But if the patient is old already and the facet cannot be approached nicely, then medial branch block is the other choice. But the block using without any RF will last only 1 month more or less. So RF is the best choice. But for alcohol or phenol, I think I won't do it using alcohol or phenol because it will make neurolysis. Neurolysis means the nerve will be destroyed and the motor function will be interfered. If we do RF, there will be some weakness to multifidus muscles, for example, but it's okay. We can give some more strengthening to the multifidus muscle by doing back muscle strengthening exercises. But if we destroy it, no more function of the motor of the medial branch nerve. That's my opinion. So let's learn the spine ultrasound guided IPM together. So we will jiggle the cases like this, because IPM is not the term of that we like to do injection, but what we want to give to the patient. Injection is easy, but how we think with wisely is the most important thing, because the very most important rule in intervention pain management is do no harm. We can do the injection, but then if other functions is disturbed, means that the risk is higher than the benefit. If there's no other option, it's okay. But if there's other options, just choose the better options. Okay, doctors?
Thank you, Dr. Novi and Dr. Dewa. Okay, Doc. Actually, we have one more question. This is from Dr. Dianti. It's not in the chat box, but she messaged our administrator because there's some technical issues, so she couldn't type in the chat box. The question is to Dr. Dewa. Why is the patient with the facet joint pain was given medial branch block instead of doing prolotherapy in the joint right away, knowing that it was the pain generator from the beginning?
Yeah, thank you. This question from Dr. Dianti, right?
Yes, the question is from Dr. Dianti.
Why the approaching is to the medial branch, not to the facet directly? As we know, the pain generator is the facet joint. Yeah. Back to the step ladder treatment. Okay. We already performed from the conservative treatment, and then now we go to the IPM. Now, in this case, we already know the pain generator is the facet joint. Yeah. So ideally, we do the injection to facet joint. But in some circumstance, yeah, you see the X-ray of this patient is very severe degenerative change and also the de novo scoliosis. Yeah, this facet is quite difficult to do injection this situation. So I perform the medial branch block that innervates the facet. Yeah, the pathological is still there, but the transmission of the film we block with the injection. Okay, and then what is the next question? About the prolotherapy, right? Oh, from the journal, right? From the journal, you can inject the facet or the medial branch, whatever you want. It is okay, but some journal also said that it's more easy to do the injection of the medial branch, and then when you do the injection of the medial branch and it work and it feel pain again to this patient in many weeks, you can continue to the RF. But if you want to do the injection of the facet first, and then patient feel subside of the pain and come again patient with the pain, you must do the injection of the medial bronchs. Yeah, and then after pain again, you do the RF. So you do the 3 times injection. If you inject the medial branch, yeah, and then you need to do the RF, you just need to injection only medial branch and it works, and then next step to the RF, because the gold standard treatment of the facet joint pain is the radiofrequency. Yeah. Okay, Dr. Chika, any question again?
Thank you, Dr. Dewa,
You're welcome.
for the answer. Okay, Dr. Dewa and Dr. Novi, maybe I would like to ask one more question, Doc. As we can see before, Dr. Wiko Hartantri is still a novice about IPM, and you suggested to join the 3MLP advanced course to know more about the question about the degenerative spinal deformity and the precautions and also the preferred techniques for such patients. So I would like to ask for novice doctors, do you still recommend to join the 3MLP advanced course on spine?
Dr. Rico, are you a specialist or a general practitioner? If you are a specialist, you can join the spine program actually, but in some circumstances, you must catch up with the some basic properties of the ultrasound, for example, and how to make physical examinations with which correlate with the MSK and nerve. And the second one is, are you rehab or orthopedics? If you're rehab or orthopedics, maybe you can catch up easier because you have the background knowledge of anatomy and physical exam related to the MSK and spine especially. So I think you will have not too many difficulties in joining the spine. But if you're a general practitioner, I'm so sorry, until now, the collegium and the common case wouldn't allow you to join the pain management that is dedicated to the specialist only. So please try to catch up with your residency program first, and afterwards you can join us together to learn more about pain management, including the spine. Is it correct, Dr. Dewa?
Dr.
Yes.
Wiko is a physiatrist.
Oh, physiatrist. Oh, so then Dr. Dewa will welcome you.
Yes. Both of us. All of
Yes,
us.
both,
All of
all of
us.
us. Yes, all of us will welcome you.
Okay. For participants who would like to obtain certificates for today's events, please don't forget to fill the survey through the link that has been sent in the chat box, pmn.page/feedback_CNU-LDT. And then I would like to announce the winners for the best questions
Yeah.
that will get gift vouchers for the 3MLP Advanced course on spine. So I think you should not hesitate to register yourself for the program. Okay, so the winners are Dr. Ninyoman, Dr. Dianti, Dr. Rizky, Dr. Kelvin, and Dr. Wiko.
A lot.
Oh, okay,
So many.
congratulations, doctors. For the vouchers, doctor of the doctors will be contacted by our administrator.
But if they're still here,
Oh yeah, okay. Are you
please show
still
our
here,
face.
Dr. Ninyoman, Dr. Rizky, Dr. Kelvin, Dr. Wiko, and Dr. Dianti? Okay, if you are still here, please turn on your camera so we can take a picture together with the winners.
Yes,
The gift voucher.
congratulations.
Congratulations. Welcome.
Welcome
Yes,
aboard.
welcome to the advanced course.
Where are you? Only two of you? Where are the others?
Kameranya.
Dr. Ninyoman, Dr. Dianti.
Dr. Kelvin, Dr. Wiko.
Good evening, doctor. I'm Wiko. I'm sorry I cannot turn on my camera.
Ah, yeah,
I'm
okay.
sorry. Thank you,
Oh,
I
doctor.
thought you're a male. So sorry.
No, doctor. Thank you for the gift. Thank you.
okay, let's have a picture together.
Okay.
And 1, 2, 3.
Congratulations.
Okay. Congratulations, all doctors, and we hope that we can see you in our next program, 3MLP Advanced course on spine, and you can learn more about spinal intervention, in Dr. Dewa's cases, lumbar facet arthropathy, medial branch block, and SI joint arthropathy, as presented by Dr. Novi.
A lot of cases.
Yeah, so don't forget about the registration. You can simply register yourself and contact our admin. And before we end this webinar, we would like to show you the videos, some videos about the testimonials from Dr. Novi and the faculty of the 3MLP Advanced course on spine. Okay, thank you very much. Once again, thank you and congratulations to the winner, to the alumni of the 3MLP basic course. See you in our next programs.
Hi dears. I've learned the hard way attending countless workshops where many arrived unprepared and went home empty-handed. That's why I've created a comprehensive 3-month learning program. It includes 18 online sessions, a cadaveric injection workshop, and a real patient workshop. Spinal intervention isn't for general injection practitioners. It's for pain specialists committed to deep and thorough learning. Our online sessions are way better than typical webinars. You'll have homeworks, one-on-one ultrasound scans, memorization of sonotomy structures, and mastering diagnostic algorithms. If you commit fully, this program will transform your approach to pain management. Join us and elevate your expertise. Sign up for our 3-month learning program, 3MLP Multimode Multidiscipline Medical IPM Learning Program Advanced Course, which is ultrasound guided IPM on spine. Take the next step in your professional journey.